Can you see the slide, guys? Peptic ulcer disease. I think this is an important topic because peptic ulcer disease, it's a common disease, especially in a middle-aged individual, male and female. And you will see, inshallah, moving forward, how to manage those cases. So those people interested in family medicine, interested in medicine, interested in surgery, general surgery in particular, peptic ulcer disease, you will see those cases in the future, inshallah. Those are the objectives for the lecture. When we talk about the etiology of peptic ulcer disease, we can really categorize them in many ways. One of the best ways is based on the culprit, based on the exact cause. So we know that H.pylori is actually the commonest cause of peptic ulcer disease, in particular the duodenum peptic ulcer disease. The second category is the medication. We have NSAID, corticosteroid, and alcohol, and all of them that are actually common ingested medication. NSAID is over-the-counter. Corticosteroid, we have tons of disease requiring corticosteroid, and alcohol in Western as well as Eastern countries are common consumption. Consumed socially. And then we have the rare disease like gastrinoma, acute stress, which is really related to the endogenous steroid in the body, as well as malignancy and inflammatory disease like Crohn's disease. The other way to categorize it is based on how common they are. So common etiology like H.pylori, NSAID, stress-related mucosal damage. This is like people going through surgery or in the ICU. Less uncommon like Zollinger-Ellison syndrome or hypersecretory acid stage, viral illnesses, radiation and chemotherapy, lucid drug use, causing vascular insufficiency, like for example, amphetamine and cocaine, as well as rare diseases like Crohn's disease. And rare doesn't mean rare diseases by itself, but rarely causing peptic ulcer disease. So up to 90% of duodenal ulcer are linked to H. pylori infection. Okay, so it's far being the commonest cause for duodenum ulcer. Idiopathic, meaning NSAID negative, they don't take NSAID, and the H. pylori is negative. And this is actually being in the rise in a population study in the US, okay? So I don't know if you can see this, but basically idiopathic peptic ulcer disease really remain unclear, but we think a lot of medication or drug can contribute to that, like cocaine, methamphetamine, bisphosphonate, which commonly used for osteoporosis, SSRI, commonly used for depression and anxiety, smoking, alcohol consumption, and stress, all being played factors in the idiopathic peptic ulcer disease, okay? And we talked about the rare causes a moment ago. So the most frequent reported symptoms of peptic ulcer disease is epigastric pain. It's not digestion, it's not GERD, it's actually epigastric pain, usually worsening during fasting and improve after eating, which is actually contradict another common GI disease, which is the biliary colic. So how to investigate for a peptic ulcer disease? Well, endoscopy is the preferred investigation. So basically, they do an upper GI, looking all the way to the stomach, looking for ulcers, whether in the stomach or in the duodenum. And they can usually reach up to the second part of the duodenum, okay? And whenever there is ulcer, usually they will take biopsies. And the reason why they take biopsies is because some of those ulcerations are malignant in nature. We just spoke about the rare causes, one of which is malignant. So we take biopsy to ensure that this is actually not malignant related, okay? So this is a CT scan to show you. If you can see, this is the first and the second part of the duodenum. So this is the junction between the two. And you see some of the contrast is all the way here in the liver. So this is extravagation, okay? So this is oral contrast, went from the duodenum lateral to the liver, basically, okay? And this is highly suspicion for perforation, basically, and have a sensitivity up to 98%. So whenever you have perforated or suspicion for perforated peptic ulcer disease, you may proceed with CT. Sometimes chest X-ray, it's actually diagnostic, okay? So what do you guys see in this chest X-ray? Anything abnormal in this chest X-ray? Guys. شكلكم ما صحصحتوا إلى الآن. Okay, you guys see this white is basically the diaphragm. Okay, and we see an air under it. So we shouldn't have air under the diaphragm. Okay, air usually is in the lung, so it should be above this line. Okay, so here, yeah, the conclusion, there is a perforated viscous سواء طبعا من الديودينم ولا من somewhere else. But we see here an air under the diaphragm. Is this clear, guys? شباب, clear? Okay, two clears. Okay, good. طيب. So we talked about the diagnostic being the endoscopy to take biopsies, but we have other diagnostic when we are thinking about H.pylori being the culprit, okay? And we can classify them to two categories, non-invasive and invasive, okay? Non-invasive, for example, we can take serology. The problem with the serology testing for H.pylori, it's not gonna tell you whether this is actually an acute infection or this is actually a resolved infection already been treated. So even if you treat H.pylori, the serology will remain positive. Okay, so the antibodies will remain positive. Urea breath test, so it's a very a good option in the outpatient setting. It's non-invasive. Basically, they take urea, they drink urea, and then you breath test them after to see whether they have H. pylori or not. And this will indicate an active infection, but be mindful, this test can be affected by PPI. So PPI will increase the risk of false negative. Okay. The third, it's stool antigen test. Also, a very useful resource in an outpatient setting. The patient can give you a sample of their stool, and you process it to see if they have an active H. pylori infection. Again, it can be affected by the PPI. Okay, what are the invasive? Invasive requiring endoscopy, requiring biopsy, okay? So you can actually do a histology. So they will take a biopsy and then you will see it under the microscope. So they will see those gram-negative organism under the microscope, which is diagnostic because no other organism can live in the stomach except the H. pylori. The second, they can do a rapid urease test. So it's an enzyme, they look for it in the sample. And then the third is basically culture. So they take a sample from that biopsy and then they will culture it. This is having a specificity of 100%, okay? But unfortunately, the sensitivity is variable and it requires trained staff and proper equipment facility to grow this organism. Okay. Okay. So how do we treat peptic ulcer disease? Well, the general strategy is as of the following. One, we have to treat the complication aggressively, and we're going to talk about the three major complications, which they are hemorrhage, perforation, or obstruction. We're going to talk about them one by one right after this. The second, we have to determine the etiology, okay? What is the cause of this peptic ulcer disease, so we can modify this cause and prevent further worsening and further relapse. Three, discontinuing the NSAID whenever it's possible, okay? Because NSAID is a notorious causes for peptic ulcer disease. Four, we have to eradicate the H. pylori infection if it's present or strongly being suspected as the culprit, okay? And use anti-secretory therapy to heal the ulcer if H. pylori infection is not present. And anti-secretory medication, we're talking about PPI or rarely antihistamine. So what are the indications for H. pylori treatment? Well, definitely we should eradicate the H. pylori if we have someone with peptic ulcer disease, if we have someone with maltoma, and we talked about that in the GI malignancy, or if they have H. pylori as well as dyspepsia. Those are indication for H. pylori treatment. When we don't treat, well, those people asymptomatic, we don't have to treat them, as well as if they have GERD. So GERD, we don't really have to eradicate the H. pylori, because eradicating the H. pylori not going to improve the GERD. Okay, those are the regime we can use to eradicate H. pylori. And in general, generally speaking, you can see the pattern. At least you need 2 antibiotic plus PPI. Okay, 2 antibiotic plus PPI. And usually it will require up to 14 days course treatment. So usually the course, for example, can be a combination of amoxicillin and clarithromycin plus PPI, okay? And for those people, for example, they have a penicillin allergy, you may use regime like PPI plus bismuth substrate, tetracycline, and metronidazole. So you see at least 2 antibiotic is needed, okay? Okay, so H. pylori infection that persistence after eradication therapy, the salvage therapy regime should consist of a different antibiotic from those used in the initial and successful regime. This is important because what we do usually in practice, if we're going to treat and eradicate H. pylori, we give a regime, 2 antibiotic, for example, 1 PPI, and then we'll check the response. So we'll check whether we eradicated the H. pylori or not. And if the eradication failed, we'll give them another course, but the course should be different. It's kind of common sense, but it's important to know because some people will keep giving the same courses, okay? And the reason for that is the following. The H. pylori have some sort of resistance to a certain antibiotic, so it doesn't make sense to repeat the course with the same antibiotic, okay? Well, how about when to test for eradication? Well, we can test for eradication after completion of therapy. We can repeat the urea breath test. We can also do a fecal antigen test or doing another biopsy. But it makes sense that to use non-invasive way better than invasive way, unless we need to do the re-biopsies. And this should be done at least 4 weeks after the completion of eradication therapy. So I will give you an example. Someone in their 40s presented with epigastric pain. They did the endoscopy. There was an ulcer in the duodenum. They took biopsy, no malignancy. You give them a course of amoxicillin as well as clarithromycin and PPI for 14 days. After 6 weeks, you do urea breath test. The urea breath test is negative. That's meaning the H. pylori being eradicated. How about NSAID? Because NSAID is the second common cause for peptic ulcer disease. Well, the key is to avoid NSAID because they are the culprit, they are the cause. And then if you have to use the NSAID, try to use a selective cyclochlorinase, which is the COX-2 inhibitor, because they are increasing the risk of cardiovascular disease, but they have less risk of GI bleed. Okay, and you always can use gastroprotective agent like PPI or misoprostol or H2 blocker, antihistamine blocker with the NSAID. And this is if you really have to use NSAID. So an example, someone with osteoarthritis, a bad osteoarthritis, and they need between time to time NSAID, and they don't have any cardiovascular risk factors. So, and they have a history of GI bleed, you may use COX-2 inhibitor to treat the osteoarthritis, knowing that it may increase the risk of cardiovascular disease. Generally speaking, PPI is the best gastroprotective agent. Okay, so what are the complications of peptic ulcer disease? Well, you see here, we have bleeding, we have perforation, and we have duodenal structure. So for the bleeding, examples, and this just is an example, people using aspirin for cardiovascular prevention. So someone with coronary artery disease, they will use aspirin and they bleed out. We still can resume the aspirin after, let's say, 1 to 7 days after, of course, the bleeding being stopped. Okay, we don't give aspirin if someone actively bleeding because they're gonna die from that. Okay, and how about the PPI? We'll continue the PPI till that H. pylori being eradicated and you test them and the eradication being accomplished. Okay. Regarding the idiopathic, we should continue the PPI indefinitely. So this is the kind of 3 scenarios. If someone with idiopathic ulcer, we don't know why they are bleeding out, let's continue the PPI for lifelong. If they think it's from the H. pylori, we should continue it at least we confirm that the H. pylori being eradicated. If it is from aspirin, well, give them the PPI, ensure that the bleeding is stopped, and then you may resume the aspirin. Of course, for the bleeding, we should do an upper endoscopy within 24 hours, and we should give them PPI even before the endoscopy. And the reason is the following. We know that the PPI only actually benefiting those people with high-risk ulcer finding. But a high-risk ulcer finding only can be found out after the endoscopy. So it's a kind of endoscopic finding. So we assume they have a high-risk ulcer finding, and we give PPI for all the people. Okay, so what are the stigma? كيف نقول and this is actually high-risk ulcer finding? Well, if you do the endoscopy and they are still actively bleeding, this is basically high risk, okay? And they have a mortality of up to 11%, so high mortality. If they have non-bleeding, but it's a visible vessels, like you can see the vessels, that's also considered as high risk. And they have a pretty much high mortality too, okay? And if you have an adherent clot, you are seeing the clots by the endoscopy, okay? This is also considered as high risk, but you see the mortality is less than that. And then the fourth one is basically a flat pigmented spot. So it's just a spot, okay? This is also considered as relatively high risk, 3%. And the least concerning is basically a clean ulcer base, okay? What to do with the perforated peptic ulcer disease? Well, it's a surgical emergency and high mortality rate, okay? So we need prompt identification, لازم نعرفها من بدري. urgent surgical intervention when they basically try to close this perforation, okay? And you may do post-operative upper endoscopy, basically to take biopsy to rule out gastric cancer, okay? Again, another air under the diaphragm here, okay? Okay, the third complication is basically outlet obstruction. So when you have a chronic, ongoing inflammation, this scarring will lead to obstruction, especially in the narrow area like the pylorus or the proximal duodenum, okay? How to treat that? Well, you have to treat the dehydration and the electrolyte disturbance because they usually comes with a vomiting. It's like our obstruction. If this is mild, PPI and treating the H.pylori and stopping the NSAID can be effective. But if it is severe or the symptoms persist, endoscopic dilatation probably it's the way to go. Okay. Do you guys have any question? يعني this is actually a very important topic لأنه just peptic ulcer disease is common. So really get familiar مع أول شيء complication bleeding, perforation, obstruction. وبعدين get familiar مع H.pylori how to eradicate and how to test for eradication. Okay. Someone asking about the indication for endoscopic for diagnosis. Well, if you have bleeding, يعني إذا واحد جايب upper GI bleed, you will have to do actually endoscopy. Okay. A second, if you suspect this peptic ulcer disease secondary to malignancy, you also do an endoscopic perforation. If it is someone خلينا نقول have no red flag or middle age or just dyspepsia عندهم, you test them for H.pylori, they are positive, you may give them يعني H.pylori eradication اللي هو الانتبيوتيك والPPI, وبعدين you test them for H.pylori, and if it is eradicated, you close the chapter. Okay. Good question. Any other question? Okay, so let's take a break and let's regroup at 8:40 sharp. Okay.